I'm Milt Schoen, and welcome to America Salutes. Today we have Tom Mullen, who is the past director of the Minneapolis VA Medical Center and past administrator of the Minneapolis Veterans Home, as our guest today. And I want to welcome you, Tom.
Thank you, Milt.
Tom has had an exceptional background, and he oversaw the construction of the new VA Medical Center when it was new in 1988, and the conversion of a system of many, many buildings that were not exactly designed to be a great medical center to a first-class physical plant. So with that, Tom, why don't you tell us a little bit about yourself?
Well, Milt, thanks for inviting me to be here. I appreciate that. It's been a while since I've seen you, and good to see you again.
Good
to work
to see
with you one more time, at least. Hopefully many more times.
Right.
All right, I'm an Army veteran, Vietnam, and I came out of the Vietnam War in '67 and went to work for the VA. So I've had a number of years working within the VA system, so I know a little bit about it, although it's changed dramatically over the years. I went to graduate school in New York City and Columbia, and then went on to run a few hospitals for the VA system. Yeah, I was director at Omaha VA, and then I became a regional director in the VA system, which had 34 hospitals under my supervision and about 30,000 employees. And after traveling every week here and there, everywhere, my wife says, you got to do something about that. So I became the director at Minneapolis, at the VA Medical Center, Minneapolis. Retired in '94 and went over to the Veterans Home, as you pointed out, in Minneapolis, and was the administrator there until the year 2000. So I've had a little bit of training there, and then I went on to be part of the American Legion's national offices. And I'm right now the chairman of the Health Administration Committee of the American Legion National Committee. I'm also a member of what's called the System Worth Saving Task Force. And the idea behind that simply is that we in the American Legion believe that it is a system, the VA system, is worth saving. But we're out there checking to make sure that we didn't make a mistake and called it the wrong name. So we watch very carefully at what's going on in the VA system. And of course, the latest and most notorious situation developed down in Phoenix, and maybe we can talk a little bit about that in a few minutes.
Certainly. And I guess one of the things I'd like to cover is that the VA was not always a overperforming system, and it had its differences with the private sector. Yeah. And there were many changes that were brought about in the '90s under Dr. Kaiser that transformed the VA system. So maybe you could say a little bit about those changes and what the actual VA system is comprised of now.
Well, the organizational structure of the VA when he came in was divided up into what's called 4 regions of the country. And these were huge regions with about probably 50 hospitals in each one of the regions, because at that time there were about 192 hospitals in the VA system. So there are about 50 hospitals, and an almost unmanageable situation. They had what were called at that time districts in each of the regions, but the districts had no line authority whatsoever. The line authority was with the regions. Well, Kaiser came in and said, this is too large a span of control. We need to break it down into pieces. And what he did initially, from an organizational standpoint, is set up what's called Veterans Integrated Service Networks, or VISNs as they call them now. There are 23 of these throughout the country, and they do have line authority over the hospitals that they supervise. For instance, in Minneapolis, there is the VISN, I could say Vision, no, it's VISN, VISN 23, I believe it is.
Right.
And they're located in Minneapolis at the VA Medical Center there, and I think there are 8 hospitals that they oversee within that VISN. So that was one of his major organizational structure changes. It brought things down closer to home and not being so wide that it couldn't be supervised. So that's number one. Secondly, he went ahead with some real changes in the way things are counted within the system. In the past, back in the old days, so to speak, keeping a patient in the hospital was actually in the best interest of the VA hospital to get money, because you keep a bed filled, you get money for filling that bed. He changed the system around into an outpatient system. He opened up what's called the community-based outpatient clinics all over the country. There are now 800 of them all over the country. These are clinics located out from the hospital and able to care for veterans in a more localized setting. Rather than having them come 50, 60 miles into the hospital, they can go to a clinic. Maybe it's only a mile or two, maybe it's about 10 miles away. But at least it's closer to home than the VA medical centers.
And there was no resistance to changing from an inpatient to
Oh,
an
there
outpatient
was.
system?
You know, I think the service organizations are our greatest ally. And I'm talking about the American Legion, VFW, and so on. But they had the concept, and it was very strong for a long time, that keeping the patients in the hospital was a good idea. Keep those beds filled. And it was hard to bring that change about. But Kaiser was a good spokesman for the VA at that time and convinced the veterans organizations this was in their best interest to go this direction. And so what we had was at Minneapolis, for instance, the hospital was built for 845 beds. It's a good thing it was, because now it's down about 250 beds, but the remaining space has been opened up to outpatient clinics. And there are clinics all over the building now in wards, or located in wards after they've been modified somewhat. They're now clinics rather than a ward. And I think the veterans receive a lot better care. The last thing I want to mention is what's called the electronic medical record, which came into play as a result of some what were called underground action by a number of physicians and nurses who needed a system that would get them away from that terrible system of records in written form, in records that would be this thick on one veteran. And they got together and they worked on it, and they were called mumpsters. And they came up with what's called the MUMPS system, which eventually grew into what's called now VISTA, which is the medical record system for the VA system. And it's probably the best medical record system in the world today. Other countries have parroted this. They have, I'm talking about France and England and so on, they've all looked at this and they've converted some of their systems to be similar to the VISTA system.
And the outcomes, as I understand it, if you're a veteran, you're 10% more likely to have a flu vaccination than the average citizen in this country, and 10% more likely to have a pneumonia vaccination. And that's one of the outcomes or outgrowths of this transformation.
Yeah, that's a big part of it. Shingles too, by the way. Very important with older people, as we have at the VA, to get their shingle shot. And I'll say that to your audience right now. If you haven't had a shingle shot, folks, go get one, and you can get one at the VA Medical Center. But anyway, yeah, all those inoculations, those immunizations are part of the way they are able to watch over a veteran. Not only if you come into Minneapolis and you're enrolled there and you go off maybe to Denver for a couple weeks, Denver VA Medical Center can bring up your record out of Minneapolis and find out what you're being cared for there, what your medications are, and so on, so that they can then treat you right up front in instant manner.
And speaking of medications, one of the big transformations was to develop a national formulary. And unlike Medicare, the VA is able to negotiate drug prices and substitute medications. And I know in the early 2000s, they said that it would save Medicare $6 billion a year if they were doing what the VA was doing with respect to medications.
Yeah, it's really unfortunate that that the private healthcare system hasn't been able to bring that about. Medicare and any of the other federal systems can't do this, negotiate for prices through the drug companies. Because it was brought up when they were talking about Part B of Medicare as being something they could negotiate. but it was dropped from the legislation, and I'm not sure I know why, although I can guess. Drug companies have a lot of interest in what goes on in their pocketbook.
And there were some outcomes. Being a county veteran service officer, we see a lot of people who have mental health issues who travel about from San Francisco to Seattle to Denver to Minneapolis. But when you have a national formulary and you have an electronic medical record, it takes much less time to stabilize an individual if they've been off of medications than it did previously, because I can recall that it took a long time to get somebody stabilized when they came from a different region.
Yeah, well, that's very true. Medications are a big part of an older veteran's life.
Right.
And any change and the interactions of medications, one versus the other, has to be in some kind of a centralized point. In the private healthcare system, I can go to Dr. X today and I can walk in there and I can say, "Doctor, I have high blood pressure." So he gives me medications for this. I can go down here to the next guy and say, "I've got real pains in my legs today, doctor," and he gives me some kind of a pain reliever. Now, there's high likelihood that this doctor's medications may interact negatively with this doctor's medications. You won't have that happen in the VA system, because every medication in the system is in the system, and it is automatically, by software, picked up as being either contraindicated because there may be an adverse reaction because of that medication versus another medication. So you don't have that kind of problem in the VA. And with that, of course, that electronic medical system, there's been a great reduction in medication errors on the wards, in the clinics, and so on, because of the rigid requirements of getting medications out of the storage areas and so on, and making sure that everything is in consonance, that medication is in consonance with the treatment program that's being provided, so that one doesn't interact negatively with another. It's a good system.
Right. And one of the elements that Dr. Kaiser put in place was to count things the way the private sector does.
Right.
And I think he said if you didn't have data on matters, you couldn't manage them. And that by setting yourself up so you could compare yourself against the rest of the healthcare system, you would benchmark yourself, and over time, you'd be able to improve.
Well, that's true. Yeah, it is. You know, you can't have a VA system that operates with a different way of looking at things than the private sector, because there's no way to measure, and I think that's what you're saying.
Right.
There's no way to say, well, this VA system is better than this system over here, unless you've got similar criteria to judge and the same criteria to judge one or the other. One of the big things that the VA system has been able to do over the years is to be surveyed by the Joint Commission. Now, the Joint Commission surveys private hospitals and VA hospitals. Every one of the VA hospitals is certified by the Joint Commission. And they look at the quality of care, they look at the timeliness of care, they look at medication errors. It goes on and on. They spend weeks at a hospital going over what's going on. And they use the same criteria for the private hospital, so that when you're being able to be measured by the same criteria by one agency, and that's the Joint Commission, and there's other agencies too that look at both, but it puts you in the same ballpark. And then you can talk about how good you are in sense that you're just as good as someplace else. It's in the private sector. So in a way, that the quality of care, I don't think has been questioned by just about anybody who looks and studies what the VA is doing versus the private sector.
And one of the big accomplishments of the VA in the early 90s, 3 or 4% of the veterans in my county were receiving care in the VA healthcare system. Today, over 25% of our veterans are receiving care, and there are over 8.9 million veterans who are receiving care. So this is a system that not only transformed itself, but it expanded greatly the numbers of people that it served.
Yeah, You know, if you talk to veterans, and there have been a lot of agencies who have come in and analyzed talked to veterans about their satisfaction with the system. When I came back after Vietnam, the VA system was not highly regarded whatsoever. As you pointed out earlier, it took Dr. Kaiser really in the 90s to bring things around and head it in the right direction. And now I contend, and I look at these hospitals, I go all over the country and look at VA hospitals for the American Legion. I contend that the quality of care within the VA system is second to none. Anywhere you can, I don't care where you are. And I'm not only pointing that out from my own vision, but there have been a number of outside agencies have looked at this. I mentioned the Joint Commission. But rather interestingly, back in the 2003, 2004, Fortune magazine, that's rather interesting, came out and said the VA healthcare system is the best system in the United States today. And it's been going on since then. The Journal of the American Medical Association, JAMA, American Medical Association, has reviewed the VA system. They're an outside agency. They could easily say the VA is not worth a darn. The New England Journal of Medicine, even Business Week magazine in the late 2010 came out and said the VA system is a quality system.
And Philip Longwell wrote his book, I think it was about 2007, The Best Care Anywhere, and
Right.
The Best Care Anywhere was the VA. And one of the elements that was advantageous to the VA was the payment system, in that they were not paid for every procedure they did, and every system has its shortcomings. In the private healthcare system, there is this tendency to possibly overprescribe or overtest because you're funded for each procedure.
Correct. Yeah. It's a different way of doing business in the VA. And I know that doctors are very conscious of making sure in the VA system, making sure they order the right tests and procedures. But they don't over-order. They order what's necessary. And that's it. Now, I'm not saying the private sector orders more than what's necessary, but there is a tendency and financial incentives, really, to move in that direction. And I think I may get an argument from the private sector saying that that isn't good, that's good medicine, to make sure that you haven't made a mistake. And maybe the VA ought to look at that and try to do more of the testing themselves, because we're sure over here that we're not making a mistake because we've ordered 20 more tests than the VA would have ordered. Well, I think I trust our doctors in the VA system, and I'm actually a patient in the VA system. I think I trust our doctors to know what's necessary, what is going to prevent the illness from growing or giving a good diagnosis. And they don't need to order well beyond what is necessary.
Well, the VA has another unique characteristic. In the private healthcare system, the average insurance company churns their customer every 6.5 years. They've got somebody for 6.5 years, person changes jobs, company changes insurance. The VA has customers for life.
True.
So it's a system that puts an emphasis on prevention, because let's say if you have a Vietnam vet with type 2 diabetes, if that's not treated right, the VA pays for the amputation, the VA pays for the rehabilitation, the nursing home care, and all the care down the road, and they don't escape those costs.
That's true, yeah. It's a system that other countries have used. The criticism of the VA system is it's a government system. And it tends towards what might be called a socialistic system, run by the government, and therefore it can't be very good. Well, then you've got to have other people come in and look at it, and they've had this happen. And others outside the system are constantly viewing what's going on. Now, the VA has had bumps along the road, and we've had one down in Phoenix.
And we should talk about the Phoenix situation.
Well,
as I understand it, you went down on behalf of the American Legion. You actually visited the Phoenix VA Medical Center.
I was called sort of. It reminds me of old military days. Called in the middle of the night and told to be on the tarmac in the morning. And because the Phoenix situation was exacerbating, and the media was having a lot of fun with this one. So we better get down there, says the American Legion National, and find out what really is going on. So I was sent to Phoenix. I was there only for 2.5 days, though. And in 2.5 days, it's hard to get an in-depth look at it. But at the same time, the IG was there, and they'd been there for 3 weeks, and they were going to be there for probably another 10 weeks, looking into the details of what was going on in Phoenix. But my visit, I thought, was constructive in that we got to know where the problems were at Phoenix. And if you want, I'll go over some of those with you.
I'd love to hear them.
Okay. Well, to start off with, the Phoenix Hospital, the system problems are these. A scheduling system that was causing a lot of problems there. The scheduling system is kind of antiquated in the VA and needs improvement. We did find that to be true. However, we also have in Phoenix I call the bump of the winter and the down bump of the summer. You've got a bulge in the winter of a lot of folks coming in, many of them from Minnesota, into the Phoenix area and demanding care. A lot of them are veterans, older veterans, and they want care. So you've got a bulge then, and that contributed somewhat to this whole business of having to put people on waiting lists out into the future. My experience with waiting lists is you've got one of three problems. You've either got a funding problem, which doesn't allow you to hire people that you need to cover that need to take more people in. That's the part of the problem, and we found that down in Phoenix. The second is facility problem. Do you have enough room to take care of them in the VA system, or are you constrained by your facilities? And they have a facility problem. The third thing is are you able to find the people that you need to deliver the care? There's a real shortage of primary care physicians in the VA and also in the private sector. It's going to get worse. So we found all three of those things exist. A funding problem there so they can hire people. A second was a facility problem in that they needed about 300,000 more square foot to open some of the clinics that they needed to open there and to expand the clinics that they had. And the third problem was to find the people that would be able to be hired. And there are just not enough of the private, in the private sector or in the VA system of primary care physicians. These are the people that would take people off the waiting list.
Right.
As far as the questions regarding the 40 people who were on the waiting list who died, there is no confirming evidence to this date, as far as I know to this day, that confirms that 40 of those veterans died because they couldn't get care in the VA and they were put on waiting lists and they had to wait. Now, people do die, and they had no relationship to waiting lists, and the IG is still looking into that. But they have found no conclusive evidence of that.
One of the elements that was brought up was the fact that there were like 2 sets of books. And there were bonuses given to senior management in the VA, and it appears that to get those bonuses, that some of the data was massaged, and that certainly is problematic in a system, and I suspect that's what the Inspector General is trying to get to stop.
I think that they're still looking at that. We asked that same question when we were there, and when I was there, and on my visit. And they showed me the lists that were electronic scheduling system lists. They said they had, and they looked me in the eye and said this, and I have no way to confirm or deny it, because I didn't have enough time to really get down into checking to see each one of these things. And that's what the IG was doing. But they denied that there was any second list or any hidden list, that this list was the one. They did admit that they had exceeded the boundaries on the electronic scheduling system, and that there was some fudging going on. They did admit that. Did that influence the quality of care? No. It was designed, and maliciously designed, I must say, by management to make them look good. and to acquire bonuses for them. So there's a problem there. And it may be that others have done this, and it hasn't been proven yet, although they've inferred that there are about 28 other hospitals have similar problems, and a clinic up in Colorado. Yeah, that is not the fault, I don't believe, of Washington offices. They had sent down directives to the medical centers on how to complete their scheduling systems. That was not followed at Phoenix. So there was culpability on the part of Phoenix, as we found, in regard to scheduling systems. Yes, that was a problem. And did they fudge or cook the books, as they say? There was some evidence of that, although the IG is still looking into that. But we found some evidence of that, despite the fact that the people there said, no, there wasn't. We thought there was. So that was a negative aspect of what's going on down there. Is it going on elsewhere? I don't know. There are a lot of teams out in the field now looking into whether this is going on in other places. When you've got an incentive, and this does not in any way justify what they're doing, but that looks at how well you're handling your scheduling system and your waiting list and gives you a bonus for that, I think you got to take a look at that as something to maybe change
or make sure you've got an internal audit function that would look at it
correct
on a regular basis, so no one would be tempted to say, if we change these numbers, we'll get our bonuses.
That's right. Yeah, and you know, one thing about, and I mentioned this to you earlier, we're talking out in the hallway, I guess, Minnesota is so much different than Arizona in its oversight of what's going on in the medical centers and in the care systems. And you know, maybe this is just the way it is in a number of states, but we found it down in Arizona definitely. Here in Minnesota, we have county veteran service officers in each of the counties. You're one of them. And they're so well organized and so watching over what's going on. And they're the first line, the first echelon. I always said that when I was director of the hospital. The first echelon is the county service officers. They see the patients, they see the veteran before we actually see them, and they certainly see them after we see them too. So the feedback we got from service officers was extremely valuable in what we were doing within the medical centers. That helped us greatly. You don't have that in Arizona.
Right. Well, now in our last minute, I guess I'd make the comment to you that I was on the American Legion Rehabilitation Committee, and we'd visit every hospital that served Minnesota. And I can recall going up to Fargo, and the comments of their staff saying, well, you're the only people who come visit us. The Legion from North Dakota doesn't visit us, so that's important. But in the last 40 seconds or so, is there any idea that you'd like to leave our viewers with? Because there's been a lot of heat and maybe not a tremendous amount of light in the press about this issue.
Well, the one issue that we found didn't change, and I think it's true throughout the VA system, is the quality of care. When you're treated within a VA hospital, you're getting good quality care. I see that, and I hear that, and I listen for that. We interview a lot of people in our visits. So quality is good. Access is a problem. And they've got to fix the access issue. And I speak from being a former hospital director and a member of the American Legion now representing veterans. You've got to fix the access issue.
Very good. And with that, I think we've come to the end of our interview, so I want to thank you, Tom, for informing our viewers. And for America Salutes, this is Milt Schoen, and thank you for tuning in.